Thank you, Dr. Taysir, على this introduction. Thank you, Dr. Abdul Hayy, for this introduction also. It's a pleasure إن نكون معاكم هنا in the AGU conference for internal medicine. I know it's early morning and everybody is still waking up. I don't know if you have your morning coffee or not, but inshallah you had. They gave me a very tough task to speak about cardiovascular risk reduction and diabetes. And I was with Dr. Amjad. I was like, I'm not a diabetologist or endocrinologist. And I know there will be some endocrinologists in the audience. So I'm not going to touch their specialty. Speak? Okay. But from the recent years, something interesting happened. This interesting in the recent, few years, their medication, okay, so they don't feel upset. Their medication touched based our patient to the degree that their medication became in the guidelines, in our guidelines. So now we are collaborating with our endocrinologist, the cardiologist, and the nephrologist, and we are working on the same kind of medicine to promote or to reduce the cardiovascular bad outcome, I would say. Okay, so basically my task today is inshallah, I hope I was موفقت في summarizing the cardiovascular risk reduction and diabetes. I have my disclosure, I have none by the way. What I'm going to touch base in the beginning is regarding the diabetes burden. So this is the scope, and some of these slides, I thank my colleagues who gave me some of these, because these slides also from my colleagues in endocrinology. So basically this is the diabetic epidemic. In the recent, like in 2011, the number of patients around 366 million. The scope in 2030 is going to be 552 million. In our region, we have 32 million, and it's going to reach around 60 million. So there is an increase of 83%. So we are dealing with some sort of a surge of epidemic. So what about in 2040? 2015, we have 415 million. It's going to be around 642 million. This is the scope. How does it look like with diabetes in the coming few years? So the mechanism by which diabetes leads to a coronary artery disease, you have the infection, inflammation, hyperglycemia, insulin resistance, dyslipidemia, and the thrombosis. All this leads into subclinical atherosclerosis. Now, this leads into what we call it atherosclerotic clinical events, mainly affecting the microvascular and the macrovascular. This is the diabetes risk of coronary artery disease event from the Framingham study. All of us, we heard about the Framingham study. When you look carefully that the age-adjusted annual rate, it is increasing for 30 years follow-up. So basically, eventually, these patients, they're going to develop some sort of micro or a macro complication of coronary artery disease if they are baseline diabetic. Now, patients with diabetes but no coronary artery disease experience a similar rate of MI as patients without diabetes but with coronary artery disease. So the risk of myocardial infarction is shown on these patients, and even if the patient doesn't have coronary artery disease, it's going to be the same. What about the risk of death? The risk of death, patients with diabetes but no coronary artery disease experience a similar rate of death as patients without diabetes but with coronary artery disease. So you see now the burden of the disease itself. Now, when you look at the survival post-MI in diabetic and non-diabetic from the Minnesota Heart Study, that no diabetes and diabetes, no diabetes, regardless of men or women, the diabetic, they have less survival. So that's another hallmark that, give you an insight that having diabetes is going to give you a worse outcome. What about the cardiovascular disease is the leading cause of death in people with type 2 diabetes? Yes, it is, by the way. So having diabetes, having coronary artery disease, your risk will be higher. What about intensive versus standard glucose lowering? I mean, from the UKBDS, proactive, our endocrinologists, they know it really well, these studies, that intensive treatment, they will do better. Today, I think they're going to have another lecture regarding hyperlipidemia. The lower is better. And the glucose intensive therapy, the lower is better, by the way. What about diabetes-related complication in the US, in the USA, from 1990 until 2010, an acute myocardial infarction. So patients with diabetes, they would have, what do you call it, more complication, basically, if you compare it with in the population with or without diabetes. What about heart failure burden? Now, we knew about the connection between the two, that they go hand in hand. You have diabetes, you're going to have some sort of like coronary artery disease. What about heart failure? Now, the problem with heart failure in the recent years, there was no specific treatment that, would save these patients, as especially diabetic, like, I wouldn't say like reverse their outcome, but in the recent years, some of the medication that was introduced for diabetes saved heart failure patients. So in the recent years, they changed the definition. We have the heart failure with reduced ejection fraction less than 40, and then heart failure with mildly reduced, which is MERF, from 40 to 41% ejection fraction, and then we have the heart failure with the preserved ejection fraction more than 50. And then they introduced also a new term, which is heart failure with improved ejection fraction, in the definition in the European Society of Cardiology. So worsening heart failure symptoms increase the risk of morbidity and mortality, and all of us, we know about this. There is 6 times greater risk of all-cause mortality for patients whose symptoms require heart failure hospitalization, and 5 times the greater risk of all-cause mortality in patients worsening heart failure symptoms. So that's a problem, how we can save these patients. Not only this, look at this. The heart failure with reduced ejection fraction characterized by frequent hospitalization. We call them frequent flyer. I like it, frequent flyer, Do you have Gulf Air frequent flyer? Repeated travel to the emergency room, repeated visit to the emergency room. The more you get admitted, or the more you visit the emergency room, or like get admitted, basically, the worse the outcome. What about the initial diagnosis of heart failure? Can be complex because the initial examination, assess cardiac function, evaluate the cause. The patient will go through a lot of panel of tests. I'm not going to name them. The guidelines have, mentioned them clearly. Some patients, they might need a biopsy. Some patients might need MRI. You will do the echo. All these things. And this is a burden to the healthcare system, by the way. So, how ugly it is ugly. I mean, heart failure, deadlier than many cancer. So, if somebody diagnosed with heart failure, unfortunately, they might have a worse outcome than cancer. I know cancer is, everybody will be afraid from, but heart failure, they have 48% in 5-year death rates. It's worse than leukemia, colon, Hodgkin's, non-Hodgkin's, and breast cancer, by the way. If there is any oncologist here, might be upset, but it is. This is the data from the National Cancer Institute, by the way. Now, what about patients with heart failure are at risk of morbid and fatal events? As many as 1 in 5 people will develop heart failure. Heart failure was estimated to affect 64 million people worldwide in 2016, and the heart failure morbidity and mortality rates are high despite advance in therapy. So we need something to save these patients. This is how it's started, by the way. This is how the repeated admissions and the rate of decline in the health of the patient and then end up in mortality. And this is how it is the mechanism between the cardiorenal mechanism between both, the heart and the kidney, and also in having diabetes on top, you're going to have accelerated process. We spoke about this, that I added here the chronic kidney disease. Dr. Amjad will be happy because, having chronic kidney disease add to the complication, add to the burden, add to the number of patients who might have worse outcome. So mortality improvement have been seen in major cardiovascular disease and atherosclerosis, but not in heart failure or arrhythmia in the US. So despite all the treatments that's available, nothing was improved the mortality in these patients, especially if they are having diabetes. And despite having all the combination of tablets that we prescribe, we tend to prescribe, we like to prescribe, medication. None, really change the scope of saving these patients. Now, here it comes, our endocrinologists, they will be happy. Okay, I'm a cardiologist, okay? So the first one is the SGLT2 and the recent clinical data. So this is some of the data. This is not industry sponsored, by the way. I'm just showing you some of the studies, and I'm keeping both, both classes of drugs. We have the DECLARE study and we have the DABA heart failure. I'm going to speak about them. And the DECLARE TIMI 58, which tested the dapagliflozin, reduced the composite heart failure hospitalization and the cardiovascular death, and slowed the kidney disease progression in type 2 diabetes patients with a predominantly preserved kidney function. It showed that 70% relative risk reduction in the cardiovascular death and hospitalization for heart failure. It showed a 47% relative risk reduction in the renal specific composite outcome, plus deterioration in the eGFR, plus the new onset albuminuria. So, plus the summary for the DABA heart failure, that the dapagliflozin is the first and only SGLT2 inhibitor demonstrating reduction in the cardiovascular death, all-cause death, and heart failure. And actually, it was reflected in the guidelines. I'm going to come shortly to it. For the sake of the time, I'm going to run quickly. The DABA executive summary, I'm showing you here the burden of the disease, all the other subclasses that you can start for a heart failure patient. The SGLT2 was showing definitely cardiovascular death and worsening heart failure reduction, cardiovascular death reduction, hospitalization reduction, despite even with the other first-line therapy, by the way. What about the relative risk reduction for cardiovascular death and worsening? As we mentioned earlier, 26% relative risk reduction. What about worsening heart failure and event and cardiovascular death? 30% risk reduction for the worsening heart failure and the cardiovascular death, 18%. What about first hospitalization and repeated hospitalization and total hospitalization reduction of 25%? So what about for the endocrinologist? It actually reduced the new onset type 2 diabetes in these patients also. All right. So and then when you go head to head to the other subclass that's available in the market with the Emperor reduce and the DABA heart failure, you have the empagliflozin and the relative risk reduction 25% for first educated cardiovascular death or hospitalization for heart failure. And for the total hospitalization for heart failure and first and recurrent, 30% relative risk reduction with a hazard ratio of 0.07. So patients with heart failure suffer from poor outcomes, and there is no clinical proven therapies to date. Fortunately, recently we are having something in hand to save these patients. Not only this, in the recent years, I think all colleagues from cardiology, they know about I show you the classes of heart failure. We have the second class, which is the heart failure with the preserved ejection fraction. Now we have something for these patients. We can start these subclasses of medicine to save them. So even if you are having ejection fraction more than 50 or 60, but you are having diastolic dysfunction, you can have something now to save these patients with a better outcome. So it was shown with the EMPA regarding the PEF with the preserved ejection fraction, that the relative risk reduction of 21%, which is a meaningful, basically, for the composite primary endpoint for cardiovascular death and hospitalization for heart failure. You have the first, it was actually the first and the only study to demonstrate consistent and clinically meaningful benefit across all prospective subgroups in regards to the doing better than the placebo. And in terms of reduced and first recurrent hospitalization, as I mentioned, 27% reduction for the secondary endpoints also. So how are we going to implement this in the practice? Yes, it is in the guidelines. It is mentioned first with the other subclasses. Be cautious as a cardiologist introducing this medicine, because you have to check the eGFR, make sure about the heart rate, because you cannot start them all together. From my experience, I don't know about other people's experience, but from our experience, you should introduce it slowly and make sure that the patient is doing well. It is mentioned clearly, dapagliflozin or empagliflozin are recommended for patients with heart failure with reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death in the guideline, class 1A, by the way. This is the expert consensus and how they are combining all the subclasses for heart failure. And we are happy, by the way, from our endocrinology colleagues. We are happy, by the way, okay? Alhamdulillah. So this is the EC guidelines and how they incorporated the SGLT2 at the top. So we actually were introducing now to our patients, and we are seeing a good result, to tell you the truth. What about the GLP1 or a glucagon-like peptide-1 receptor? Maybe some of the cardiology colleagues haven't heard about it. It is there in the market. There is a short-acting and long-acting medication. I'm going to touch base quickly for the sake of the time. So we have the GLP1 or receptors have multifactorial effect in regards to the pancreas, GI tract, kidney, and the muscle, and lipotoxicity. So in the recent year, they were the authorities, research authorities, they were demanding from endocrinologists when they do their study to have a cardiovascular outcome. So this is how it started, because most of our in cardiology in our field, we always test the outcomes as a primary and secondary with MACE and all these things. Unfortunately for the endocrinologists in the previous studies, some of the studies they did not test. So now it's required from them now to test and make sure, because you are just pushing some tablet and you don't know the effect. This is the cardiovascular outcome with GLP-1. It was conflicting data, by the way, except the SUSTAIN 6. This was showing some benefit in regards to the starting these drugs and like having a better outcome in terms of cardiovascular death, non-fatal stroke, and non-fatal MI. Okay, so the endocrinologists, they were like, well, I'm seeing a good result regarding glucose, but I'm not having a good result regarding cardiovascular outcome. Plus, I'm also reducing the weight of the patient. A lot of patients, by the way, are taking this to reduce their weight. Is that correct? They are, right? So the background, as I mentioned, type 2 associated with high risk of cardiovascular, microvascular, and other complication. I have 2 minutes. I'm going to finish shortly. As I said, the regulatory authorities have mandated cardiovascular outcome. The liraglutide showed some sort of benefit in terms of cardiovascular death. What about the cardiovascular death is also showed little bit of benefit. There is a tendency. In myocardial infarction, it was not significant p-value, by the way, but there is some sort of tendency. In terms of a stroke, yes, there is tendency, but it's not a significant p-value. And if you look at the individual, there is a tendency. It's doing better, but still. An expanded MACE, yes, it is. An extended MACE, it is showing some sort of good data. In terms of all-cause death, not that much, by the way, for regards to the data. Hospitalization, not that much, by the way. What about the leader result for the, so it's showing 13% risk reduction, 22 risk reduction, 15 risk reduction in terms of, as I mentioned, cardiovascular death and all-cause mortality, and non-significant for the non-fatal stroke and non-fatal MI. What about long-acting? Namely, we are looking at the, 1 minute. This is the last slide. Okay, and in terms of the semaglutide, okay, so I can go to the conclusion. So the GLP the long-acting showed a little bit also tendency for a better outcome for the non-fatal MI and stroke even. Okay, so you can see the line is separating early. And for the cardiovascular death also, not that much, by the way, so don't depend on that. In summary, so type 2 diabetes is associated with high risk of cardiovascular, microvascular, and other complication. The regulatory authority have mandated cardiovascular safety assessment of a new diabetes treatment, and I think it should be. The glycemic control is associated with a reduction in microvascular complication. Effect on macrovascular benefit is now seen with newly introduced SGLT2, and there is a tendency in the GLP1 RA. The SGLT2 inhibitor at treatment showed a beneficial outcome in patients with heart failure with reduced ejection fraction and heart failure with the preserved ejection fraction by reducing the risk of hospitalization and also cardiovascular death. Half of heart failure patient, I think half of these patients have shown a good benefit, by the way. So I thank you, and later on we have maybe questions, inshallah.